before I became a clinician researcher, intracerebral hemorrhage was really personal to me. My two paternal grandparents died from bleeding in the brain. And at that time, I didn't really understand the whole medicine of it. What I understood was how things change really quickly for a family. One moment you're sort of moving really forward, and the next moment it's chaos and crisis. And I was a young carer for my grandfather, who we were able to bring home after hospitalization. But I didn't get that chance for my grandmother, who died when she was admitted to ED. And so at that time, and so now as a stroke neurologist, I see that sort of devastation again and again. And stroke happens suddenly, but when stroke is caused by bleeding in the brain and intracerebral hemorrhage, it's often very severe. And patients can deteriorate quickly, and families are forced into life-changing decisions in a matter of hours. For many years, there was nothing to do except supportive care for people who've had intracerebral hemorrhage. But now times are changing, and treatments are being discovered. And so from the work we've been doing in the brain health program, we've found out that very early blood pressure lowering can change lives and can improve outcomes. And when I say early, I mean even 20 minutes brings about this change. And the challenge is that paramedics in the ambulance still cannot tell the difference between an ischemic stroke and a hemorrhagic stroke, or a blocked artery and a bleeding in the brain, without a CT scanner in the ambulance. And we know that there are only 2 of those in Australia, and they're hardly scalable. They cost millions of dollars. And so this diagnosis then has to wait when a patient gets to the hospital and gets a CT scan. And so there we lose sort of a lot of precious time. And this is what drives my work. I lead the INTERACT4 expansion study, and it's a study testing, looking at a simple biomarker, a simple blood test, a pinprick even, on what we had during COVID, one of those lateral flow devices in the back of an ambulance. And this can identify whether a patient has had an intracerebral hemorrhage versus an ischemic stroke. And that's really important, because the differences between the treatment, they're sort of polar opposites. Our goal is to move safe blood pressure lowering forward into the ambulance while the patient is in transit. And at its core, the idea is really simple. The earlier you diagnose a patient, the earlier they get treatment, and the more likely their outcome will be improved, to the point where they might even walk out of the hospital instead of going to a nursing home. So this can be a game changer in many places, but especially in rural and remote communities where patients may spend much longer time getting to hospital. And those extra 15, 30, 60 minutes are not just transport time, they are a window of opportunity. And to me, this is one of the most exciting frontiers in stroke research, turning the ambulance into the very first treatment room. And we've been working really closely with New South Wales Ambulance and Ambulance Victoria, so that when the trial finishes, we get that immediate sort of translation into the real world setting. And because for families facing intracerebral hemorrhage, earlier action can mean the difference between a catastrophic outcome and a chance for survival, recovery, and more life lived at home. And this is why this matters to me as a clinician, as a researcher, and someone who knows that intracerebral hemorrhage is not just a diagnosis. Thank you.